You see, I'm just straight busted jamming. Good morning.
Good morning.
How are you?
All right, and yourself?
I am well. I am well. We are here. It is Saturday. We done made it. One more day. One more day. Oh, how's it going? How's the weather?
Pretty good.
Yeah.
It's okay here. It's kind of
Yeah,
over.
it's a little. Yeah, yeah. We don't have no bright, pretty sunny. It was so pretty yesterday. I think the last couple of days it was been pretty, but it's like whatever. All right, look at the folks out here early in the morning. Good morning, Miss Tanika. Good morning, Renita. Good morning, Miss Carmen.
Good morning,
Yes,
everybody.
hello, T fam. T fam. Yes, yes. We out here. We out here in these here internet streets. Got my tea ready. Got my tea ready because, yes, all of the things. Oh, wait a minute. Let me put my focus on because it will be just my luck. Somebody will call me in the middle of this broadcast and I would be so upset. Okay. Well, welcome everybody. Welcome to our Saturday morning tea where we discuss health information, news, education, certification tips, entrepreneurship, the weather, all of the things, the weekly ups and downs, all of the things, even though really it's all about the revenue cycle at large. So as you come in, don't forget to hit the thumbs up or like button so we know that you are here. I am Clarice Warner. I am the girl with the pearls, the founder and senior education director, that almost didn't come out, of the Professional Reimbursement Network, LLC, where coding education is key. And PRN is a healthcare compliance consultancy located in Cincinnati, Ohio. Yes, Ohio, the heart of it all, that specializes in revenue cycle and regulatory compliance and education. Now, let me ask, do you know what it takes to be a certified marketable medical coder? Emphasis on marketable. Do you? Well, before I introduce my co-host, let me share with you information on a free, free, free 99 email course on the 5 steps to become a certified marketable medical coder. Are you interested in medical coding, but not sure where to start and scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder. Hey. Okay. I feel like I needed some more tea because I felt a Barry White spirit in my throat. And I'm like, wait a minute. What is happening here? So if you are interested in getting more information about the 5 steps to become a certified marketable medical coder, then check out the video description for the link. So joining me today is my illustrious co-host, Mr. Jesse, the registered trademark. Put some respect on his name, the coding nurse. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia. I have been in healthcare for over 30 years. In 2014, I transitioned into the wonderful world of HIM. During the pandemic in 2020, I created my company, the Coding Nurse LLC, where I help nurses and other people in healthcare with a clinical background transition into the wonderful world of HIM.
Oh, and what a wonderful world it is. And how is everything going with that?
It's coming along.
It's coming along. Okay, look, I feel like my everything is just off today. What is happening with my set? Okay. Like everything is off. All right. Well, you see some behind the scenes things. You see my mic. You see you see my books, my references down here. You see it all. Okay. Well, before we jump in and start our conversation, let me remind you that this is a conversation. And you know, a conversation is a two-way communication. In this case, three-way. Me, Mr. Jesse, and you. So feel free to be a part of the conversation. Don't be shy. Your opinion matters here, and it is welcomed here, either pro or against. It is welcome. How do you communicate with us, and how do you become part of the conversation? Well, you use the chat. You use your little fingers and you type to your heart's content. Some of you may even have a voice chat, so you can just hit that voice button and be able to talk to your heart's content. However you move, just use the chat and join us. If you have a question, please type Q first so that we know it is a question for us and we don't miss it in the conversation. Because the chat does be buzzing. For those who are joining us or watching the replay, again, welcome. Today we are talking rethinking coding's role in CDI. I don't know if you read that. And upskilling for AI's rise. Both of these put a little chuckle in my spirit, so I'm sure we're going to have some lively discussion today.
Absolutely.
That's why I made sure I got 3 tea bags. I'm not playing with you. But first, let's get into some of our church announcements. Yes. I need a little baby tambourine in here too. Don't get me started. I mean, I had a whole tambourine moment. Yes. All right.
Once you have the tambourine, then you're going to work up to a professional.
You know, it's going to be a whole thing. I'm going to have a solo moment, everything. You know, we're going to have a whole church. It'll be like, really, y'all? Really? Like, yeah. Sometimes it becomes a lot. All right. So my one church announcement, I only have one, and I'll reach out to you guys to see if you have anything. Good morning, Carolyn. Good morning. Welcome. This church announcement is primarily for the state of Ohio and the providers in Ohio. So you should have received an email, and I know how usually that goes over with folks. Let me think. I think how that usually goes over with folks. You know, people get all kinds or bombarded with emails, and they'll be like, I'll read it later, and then later never comes. However, this was important. The PERM, or payment error rate measurement program, is coming to Ohio again. It's now in progress. And what that means is that for your Medicaid services that you have billed for, they will assess the PERM, CMS's Center for Medicare and Medicaid Services. That program will assess the payment accuracy rate for Medicaid and CHIP programs. They're going to pick a random sample, and if chosen, your organization will receive a medical records request from the CMS review contractor, which is Empower AI. So you need to be looking out for any type of request notification from Empower AI. This cycle measurement will review Medicaid and CHIP payments made in the reporting year. So the reporting year is 2025. However, they're going to look at claims from July 1st, 2023 through June 30th, 2024. Those are the claim parameters that they will take a look at. However, it's really, 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 really important for you to communicate, and once you get that request, that you send them the documents. Don't get in trouble for not sending the documents. Please be advised that the Ohio Department of Medicaid may recover payments made to sample providers who fail to cooperate with the CMS contractor by the established deadlines. So they can take the money back from those claims that they are asking you to submit for failure to be a part of the process and provide the information. Don't get caught slipping. Do what you need to do. It's expeditiously. In the words of my friend T.I., expeditiously. Providers who are no longer doing business with Ohio Medicaid are obligated to retain recipient records for 6 years from the date of payment under the terms of the provider agreement. So if you are no longer providing Ohio Medicaid, if you have provided Ohio Medicaid during the time that they are looking at these records, you still part of the program, and you still have to submit your information. So just a friendly reminder, check those emails. There's actually a video out on the Ohio Department of Medicaid website that further explains the process. If you are in a revenue cycle capacity with a provider, make sure your providers are aware, make sure they know this is coming down the pike, and make sure you guys submit those records when you get those requests. That is my church announcement for today. And I believe there were other states, but of course I'm just in Ohio. So there are a few states that got picked for the perm this reporting period. So be on the lookout. Check your state Medicaid website to see if that's part of you, or check your own email. I'm sure that hopefully they sent a notice to let you know that this was coming. Mr. Jesse, did you have any church announcements you wanted to share, or even any comments on the perm? No. Okay. Alrighty. I don't see any comments from the folks out here. Okay, well, that will conclude our church announcements. We would lead you back to your seats so that the program can begin. And you would think I would be sleepy, but I had enough sleep today, so I don't know. I'm just in a silly mood. All right, so let the tea spilling begin. All right. So I came across this article this week from Kim Graham with Littman Education, and she said it's time to rethink the coder's role in clinical validation and documentation integrity. Yes, she did. Of course, we all know that if it isn't documented, it didn't happen. But she said that in today's age, part of that is an issue, because we are now, the coding people then become part of a downstream process that is away from the provider, with minimal opportunities to discuss any type of documentation issues. Primarily, as coders, you got what you got. If it was there, you coded it. If it wasn't, you coded it, and you went on and on to the next one. Well, of course, now we have a totally kind of revamped that process with CDI, where at a point, there is someone who is actively looking at the documentation, actively going after any type of denials. And she states that coders need to, quote, wake up and recognize that documentation is a team effort. She says providers may start the process, but a well-run documentation integrity program draws together the provider's assessment of the patient, the clinical knowledge of the CDI staff looking for ways to make the documentation more complete, and the coding staff's in-depth understanding of what the coding systems require to ensure that the final codes are accurate, by the book, complete, and defensible. Mr. Jesse, jump in at any time. I see it all on your...
No, I'm serious. Like, I'm not understanding what her point was, because I'll just start right there. Like, is she trying to say that coding should take more of a role, or like I just wasn't sure. Like, so what do you think?
I, I'm with you because it seems like in some of the next sentences, it's like you need to stay in your lane. Everybody needs to kind of find their lane and stay in your lane. But what do y'all think? Anyway, let me tell you more. So, let me get into the right screen here. Good morning. Not from Aquatica, ma'am. Ma'am. Okay. um, so she says that in order for this to happen, it is essential for coders to have good working relationships with providers and CDI, which I think we all agree. We understand that. That's should be a given. Coding to the highest level of specificity can only be achieved when the documentation is there to support it. I think we all understand and agree that. And now is not the time to be working in silos. When clarification on documentation is required, coders need good communication skills in order to efficiently and comfortably confer with their CDI colleagues on when and how to query the provider. Mutual professional respect should be expected. After all, most coders possess in-depth knowledge of medical science, either from school or what they have learned on the job. While coders may lack patient care experience and hands-on clinical knowledge, they bring to the table their detailed knowledge of the complex and sometimes conflicting rules and guidelines that govern how codes may or may not be assigned. Knowledge that the providers and CDI are less likely to possess. In my experience, coders at all points in their careers do not need to be prodded to expand their clinical knowledge. Coders work hard to keep up with changes in medical practice, new devices, new techniques, new approaches to conditions that offer great hope to those afflicted. A skilled coder's knowledge of coding guidelines coupled with a critical eye towards the documentation helps to ensure the final coded diagnoses are clinically valid. So she believes there needs to be collaboration between the providers, CDI, and coders, and this would make everyone's life a little easier. She feels it takes a team to create truly good documentation. And that was from Miss Kim Graham over at Lippman Education. And some folks have been very, very vocal as well. One person, so much so, said coders need to understand the clinical signs, symptoms, and treatments of conditions just as any CDI or individual reviewing the record for documentation should do. I totally agree. Yes, it was true back in the day before DRGs and the opportunity for fraud. Coders were only expected to understand coding guidelines, but that changed well before CDI came into the picture. Coders have been querying physicians to rule in and rule out diagnoses for decades. Adding CDI wasn't because coders couldn't do it. It was because physicians routinely ignored coder queries because they were focused on caring for the patients in the house. The delays in responses or complete absence of responses was the motivation to get CDI on the floor while the patient was in to improve and accelerate reimbursement. Many will remember concurrent coding, yes, an effort to solve the same issue, but adding non-clinical bodies to already full nursing stations never really worked for a number of reasons. Oh my God, I remember that. Oh, that was a mess. But anyway. Because you couldn't focus, stuff would be everywhere. You know how busy and crazy that nursing station is on the floor. Oh, okay. Anyway, the clinical signs and symptoms of health conditions isn't something that you only learn by providing bedside care. Quite the contrary. Girl, you better tell it. This came from Jean Carmen. You better tell it. The nature of the Merck manual and others is to do just that. Define clinical conditions. Those who provide care first have to learn how to recognize it. The core of good documentation demands that the clinical signs and symptoms that support the diagnoses are documented. That means that anyone who can read a medical record is fully capable of identifying those same signs and symptoms. What a coder can't do is provide bedside care. With that said, recognizing that a patient may have respiratory failure isn't limited to those individuals who are standing at the bedside if the documentation is as it should be. Since the inception of DRGs, APCs, and the like, our whole industry has shifted, and everyone, physicians, CDI, and coders, have had to step up to make sure all hands are on deck to ensure the organization's patients are accurately and fairly represented by the codes that summarize their visit. Absolutely. Mm-mm-mm. I think she said a mouthful there. Mr.
She
Jesse, what you
did.
got? Like, first of all, I'm not a fan of anybody trying to minimize anybody in what they need to do. If you are in a role and you have uh, um, tasks that need to be accomplished, and if there's some things that you may know you are deficient in completing those tasks, then you have a right in order to get whatever tools, resources, information, and education needed to complete those tasks for the job that you're doing. So to say, oh no, you don't need to worry about that. That's somebody else's role. Stick to your role. Absolutely not. I don't agree with that at all.
Well, that's what CDI has done. You know that they have, man. Listen,
No,
we
but even in your experience, you've seen where first and foremost things are kind of, and we're not going to talk about our friends who are offshore. We're not talking about them. So that's a whole other conversation. But even that first pass often comes from a coder, or that even the first code comes from that coder. If that coder is knowledgeable and knows how to look for signs and symptoms, knows how to do that work, then that makes the load of the CDI professional, I won't say lighter, but maybe different, because you know that you got somebody who is trained, who understands, and who didn't just slap a code, who just didn't say, "Oh, I just see this and here we go," without actually doing the work of a coder. I believe all of that part, to me, that is part of what a coder's job is. It should
but
be.
the process you just described does not happen.
How does that happen?
I work in CDI every day, and that is not how it goes. The problem is they have separate they have white women have gate kept CDI because you have to be a nurse. That's how they
Right.
have gate kept it.
Okay.
And what they do is they attempt to play around with trying to assign a diagnosis, and it's on coding to fix it. So
Well, that's
when coding,
contrary to the whole. Oh
but
Lord.
I'm telling you how it works.
Okay.
So when coding contacts CDI, that CDI, well, we don't have the same DRG because of blah blah blah. The I'm telling you, I see it all day. They're in the chat. Well, the coder wants me to send a query for this, and then they have a conversation. Why would you cannot do CDI without coding knowledge in 2024? That's just it, point blank, period.
Right.
And nurses will fight it because they have been allowed to gatekeep and think that they do such a higher level. There is nothing harder than medical coding other than direct bedside care, period. So when you leave the bedside, you're no longer, Becky with the Littman stethoscope. So you have to learn in order to do your job. And so much so, this is how Actis came up with that 2-year requirement, because it takes them at least that long to even get a clue about what they're supposed to be doing for their job, because they don't. They call themselves training them, but they don't know. The learning curve for a new CDI is extremely steep.
Mm.
If I did not have a coding background, I would be just as lost as most of them. Because how can your job be assigning the principal diagnosis? The principal diagnosis is a code.
Mm-hmm.
So how can you assign the appropriate code for this encounter if you
If
don't
you
know
don't
code?
know coding, exactly.
That's what it is. So, and they try to come around with this high level. It's all BS, all of it. And this is exactly why healthcare is the way it is. And you wanted to separate offshore, but you can't separate offshore because that has made it worse. Because now you have CDI who
Well, I
don't
just
know.
wanted to make it a different conversation. It wasn't part of my
But
thing.
it's
But go
but it's
ahead.
all, it's all because you have CDI who don't know. Then you got people 10 hours away who still don't freaking know. So it has created a problem. And nobody wants to address it because what really needs to happen is they either need to train coders to be CDI or train CDI to be coders.
Mm.
Period. That's the only way around it. But they're not going to do it because they're not going to be out of because they're not going to be forced out of the comfort zone because learning coding is not easy and
I
it takes
agree.
time.
But I feel like, so where did the coding training stop? Because I feel like,
It never started for CDI. That's the whole thing. It never started.
uh, mm,
They do MDC training. They try to teach them a high-minded level of DRG assignment, but you cannot separate that from coding. You just cannot.
okay. So I remember, I'm dating myself. I remember back in my coding training, kind of we learned to us to clinically view this record, to clinically understand, and maybe now that I'm walking myself through this and talking myself through this, maybe all of that went away when these certifications came into play, because then it became more important to get a coding certification to say that you are proficient in coding, but not necessarily proficient in the clinical thinking skills that are necessary uh, to code. I don't know. I just remember us having to go through. There was a reason you had a pathophysiology class. There was a reason you had AMP. There was a reason that you had to go through pharmacology. There was a reason for all of that, because you had to be able to go through the appropriate documents to pull out and to assess and say, well, wait a minute, we see this. Why is this not reflected um, in the doctor's documentation in the final statement? Why is that not reflected? And then that's when, again, this was pre CDI before it, but because the coder would be the one that would say, well, doctor, I see such and such and such, da 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 da. They would then do the querying. They, okay. Okay. Ooh,
The entire thing needs to be revamped, but it won't. It won't be because it's going to ruffle too many feathers.
I agree with
That's
that.
that's just the bottom line. So and that's why in my coding class, because I mainly teach RNs, that's the majority of the people. And I tell them, look, if you want to lead the bedside, you have to learn coding, point blank, period. And if you learn coding, you will be able to set yourself apart and be able to make a ton of money. Because I told one of my students, what you know now is more than what the people know that I work with every day. And one of them now is my coworker.
So I'll come back to that. Okay, it says it's not just a one and done. You can code correctly, and the insurance will still deny a claim for payer rules. It's so many levels to it. You're absolutely right. Ooh, I love when turn them every way but loose. Jesse is activated, wasn't he? Wait a minute. When the hands started clapping, it became something totally different. White LPN here, bedside nursing in multiple areas for 17 14 years, and I agree. No DRG experience, but I have been working in SIU for a major payer for 2.5 years, and it is so much harder than bedside. You better preach, Mr. Jesse. Nothing but facts. I think it started to decline when productivity. Okay. I'm trying to figure out like when, because I guess you don't have the time to really go through that record and do what needs to do if you got this target on your head that you need to get so many done at a time. You don't think so?
Because what they did was they separated it. Because before, the coder would have more time to go. Coding productivity is really why all of this has gotten out of control.
That's what I think that's what she means. Coding productivity, not necessarily CDI. No.
You have, like, I mean, sometimes I have somebody that's in the hospital. I have 10 days to read these notes and to kind of figure it out, or to even be able to ask the right questions to the doctor. I really think that if they really made nurses learn coding and then come into CDI, this whole thing would change. And see coding as an ally, because I can tell you the thing I learned the most on this job is how to write a query. Now I'm good with it, because they have to be very specific, and you have to address specific concerns. They have to be worded a certain kind of way. You have to present certain kind of information, and that takes time. It really does. Well,
have you was I'm did you know that AHIMA had that query? Was that helpful? No. Okay, I was just asking.
The only thing you need to know is that a query. The only thing AHIMA taught me is that queries can't be leading. That's it. But how to, like, their query information is too broad. Like, you need.
So they didn't get down to the exactly how to with examples and template. Okay.
Right. Now
it was just a pie in the sky.
Right. They talk about it, but it's not in any tangible way, in my opinion.
Okay, I can appreciate that. Okay. She said yes, productivity trumps quality every single day. Yeah, I mean, because you're focused and you're pushed to say, I gotta do, and you don't have time to really look at the documentation and pull out what is necessary. And I hate that. And like I said, I hate that this still feels like a battle between coder and nurse to me, even though they're all sitting at the table in this CDI role. I still feel, even if you're not part of CDI, but you are part of the coding team, that you still need to bring these types of skills into your role. And unfortunately, due to all of the things I think we've discussed here today, that just is not the case anymore, which is unfortunate. I think that's where we've even talked about, like, who are these coders that are out here in these streets doing some of the coding? And if you're not bringing that information and education and skill that you have to the table, hopefully that you have gained and learned, then are you... You're diluting the profession to me. I don't know. I don't understand.
Well, what has happened with coding is, I mean, coding has not gotten the respect because of nurses. Nurses inserted themselves in this. They weren't ever a part of this. It was always just coders who did everything.
Correct.
Nurses inserted themselves. They inserted themselves and they drove a wedge. And they all they tout is, my clinical knowledge. Okay, well, if you worked in the ED for 20 years, you still don't know how to code a daggone totally implantable vascular device for chemotherapy. What does that have to do with anything? Nothing.
Mm-hmm.
But they make it like your clinical knowledge makes you so much better. No, it doesn't. You read a record, and if it's very clear if you're a coder, if the acuity level of somebody's congestive heart failure is not documented, but you see that they were given IV Lasix. You see that they have lower extremity edema and their BNP is 1,000. Then you know that you have to query for the provider to tell you, is it acute?
Right.
Acute on chronic? Is it chronic? Are you unable to determine, or is it something else?
Correct.
You can
Correct.
be Anybody can be taught that.
You can be taught that. And I feel like at some point back in some day, we were. And it
But
seems like, or it feels like that's gone away.
I'm telling you why. Because
No, 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 I get it. I hear you. I hear you. But that's unfortunate.
if they trained coders, there would be no nurses in CDI because they wouldn't be able to compete. I'm telling you, I see it every
But
day.
they used to. And I'm like, why did they go
No,
away? Again, because you felt like the nurses had inserted themselves.
because nurses never knew. Never.
Right.
I have I have a coworker who's been in CDI for 15 years. She's still almost week, at least 4 times a week. She's talking to me about how to code something or what should be the PDX over something like over like adverse effect versus poisoning. No, seriously. Because
Oh,
that affects it. If you put that code in the wrong place, that goes into a whole different DRG. But I know that because I'm a coder. I mean, and these are nice people. Their personalities
not they nice people.
has nothing to do with the knowledge you need to do your job effectively. And you have to be able to anything that you code or pick, you have to be able to support it. And the reason why there's so much back and forth is because nobody's sure now, because they don't have the requisite knowledge. Like, and then we have these other departments that get involved. There's some kind of auditors. I don't know where they are, but I don't agree with most of their recommendations because they want you to query for ridiculous things. Like, for instance, I had a case where the person had bilateral internal carotid artery stenosis. The vascular surgeon definitely did not agree with the percentage of blockage, but you had to read the note that he put to say that this person's bilateral internal carotid artery stenosis was not clinically significant. So I sent a query to the attending. So the attending said the person had a TIA. That was the PDX. Me and the coder agreed it goes off. So then they come back. This other department comes back and says, well, can you send a query? A query needs to be sent to a staff for the relationship between the bilateral internal carotid artery stenosis and the TIA. How? So I wrote back, I disagree, and here's why. With that little blurb that the bilateral internal carotid artery stenosis was not clinically significant. What do you want me to query? For what? And that goes on all day long.
Wow. I it just wait a minute, let me see. Did I show this? Yeah, she says they say quality over quantity, but productivity expectations insane. Um, I think it has to be taken into account that the upper management will post these jobs and only require nursing credentials. Yeah, we've seen that. Um, I want to say that. Supposed to say they act like they can train coding in a few weeks during onboarding, and it
It's just
just
not
is not
possible.
possible. Coding takes years to really learn, in my opinion. I agree. I feel like, and maybe this is just a conversation with um, kind of some educators as well, because I feel like there's a knowledge deficit that is happening here with our coders. I feel like, and this will segue into our next thing about the upskilling for the possibility of, well, the future of AI. I can't even say the possibility because it's here, for the future of AI. Because I feel like they done dumb coders down to just a basic assigning of the codes, which is, to me, never what this was in the beginning. That was part of the job, but you had the clinical knowledge. You were, at least, again, I can only speak for my training. We were taught that. We were taught all of that. And now you're not, which again allowed that gate to be built in the first place for it to be kept by your nurses. But if you couldn't show that you possess the clinical knowledge and your coding skill, I mean, you were a force to be reckoned with coming out the gate, bringing both of those to the table. And if you're lacking, then of course somebody else gotta feel the need. And so if they're not being taught that, if they're only being taught that but not taught how to use it or utilize it or to apply it to these real world scenarios, then I mean, really, what's the use of teaching it if you're not allowing them to apply it or teaching them how to apply it? I think somewhere there's a disservice. Right. She says they act like it's data entry. That's what it sounds like it's becoming. It's dumbing it down.
It has been reduced to data entry. It wasn't always like that, but it's been reduced.
No, that's what I'm saying. Like, no. So this has been eye-opening for me. I'm always walking away with a learn. This really has been eye-opening to me because now I can appreciate the whole, oh my God, AI is about to take my job. Well, hell, if all you're doing is the data entry, yes, AI will come in and swoop up because AI can do that. Wow. So I think there are a lot of folks that need to be having conversations, particularly.
But it's not going to happen. It's really not. Like the only way around all of this is everybody listening, or who will watch the replay. If you are trying to be an HIM, point blank period, you better learn coding. I'm talking about learn it, not just say, oh, I have this credential, but know what the F you talking about. Like, don't code no crazy stuff. And stay educated, stay abreast of all the changes. And that's how, you said every week, that's how you become marketable. Because you have to, at the end of the day, now it's about knowledge. Like all these people who have been finessing and faking the funk, they are going to be smoked out. And people don't see it. And the best thing I ever did was decide to teach coding because it requires me to stay abreast of all the guidelines.
Exactly.
All the time.
Exactly.
So that's why I'm so sharp at my job. It's not because of anything other than the fact that I have to stay abreast because I teach it. I have become, over these past 4 years, I've become a much better coder. I thought I was good then, but I'm really nice with it now.
It's a disservice because it's only about passing an exam at this point, not really about the profession and what you need to do to be a good coder. AI will take your coding data entry job quickly if you just winging it. Absolutely. And credentials are entry tickets to the circus.
And AW727, you get it because you're a nurse. Just like any nurse. When you finish nursing school and get that license, you're nowhere near ready to be nurse of the year. Nowhere. It takes you years to become a good nurse. Because you have to get that experience. School only teaches what you need to know to just not basically kill somebody. And once you get out of school, that's where the real education begins. And it's the same with every credential you have. Once you get any kind of credential, whether it's RHIA, whatever, that's just like AW727 said, that's just the entry. Now the real education begins. Because what they teach you in school and what you see in real life is dramatically different. And you have to know how to navigate real life.
You ain't nothing at graduation. Wow. Interesting. Well, like I said, this kind of segues into the AHIMA article on artificial intelligence and upskilling the health
Well,
information workforce in the age of
one more
AI. Yes, sir.
before we transition into that, I've been telling y'all the next gatekeeping profession for nurses is going to be, well, for RNs. I ain't gonna say nurses because we're the LPNs are the redheaded stepchildren. But the next thing is going to be data analytics. They coming. I see it, and AHIMA's going to be behind it. I see it coming. You heard it here first.
Oh, yeah, I know how I love when we get the you hear it here first thing. So give us some more insight on that.
Oh, okay. So, truth be told, when it comes to data analytics, nurses could dominate. But once
Okay.
again, you have to have a skill. Coders could dominate, but you have to have a skill because the part that is missing right now is everybody wants to have a high-minded, everybody wants to work around coding because they don't know it. Coding is the key to HIM point blank period. And if you know coding, you can be able to abstract any data you want because everything in healthcare is coded,
It's
has a
like
code
this.
associated
That's
with it.
right. That's where they get the data from. That's how they. That's
Once
yes,
you
yes,
learn
yes.
the code, once you learn the the language of data analysis, like once you learn Excel, once you learn SQL, once you learn Python, all you do is you take those code, you can structure queries to pull out the exact information that you need. Then you put it into Tableau, make a nice visualization or Power BI, and you look like the smartest person in the world. But they are trying to gatekeep because they're trying to make data like they did CDI, where you have to have this deep clinical knowledge to figure it out. No, you don't. You need some, yeah, but you need more coding than you need clinical experience, in my opinion.
Right.
Because don't nobody, because when you're reading
When you
those,
running those, putting in that information, they not putting your clinical experience in there. You putting a
it
code in there to
has
pull
nothing,
the data for what you need.
it has nothing to do with how long you worked on Five West. Nothing.
And data runs the world. We all know that data is running the world, and we are data miners. We are data keepers
Yeah,
as coders. So you're
yes.
absolutely correct. You're absolutely correct. All right, we need to get into some of these data analytic going out to YouTube University. Let's find some good folks out here in the world to. Well, you also mentioned what's it? Udemy. I think you said something. There were some things on Udemy. I'm sure there's some things on Teachable. I'm sure some things everywhere. Let's see. Carmen says my coworkers had to form a community to learn the job we had, not education or guidance from anyone in a higher position.
Because they don't know.
I also agree. Also, it's hard to keep the clinical mind under control so we don't infer things that really aren't there in the record. I struggle with that sometimes. Yeah, you tell nurses all the time, like, this is not your patient. You can't assess. You have to go by what is in the record as a coder. You know that's a skill set too.
And it's a very real one because I have to tell
Hmm.
like how my students are in week one are very different how they are in week eight because because you can't play that what if game because you'll never get it done. It's not about what if, it's what does this documentation say, and what about it. Doesn't It's not about what about. It's about
Hmm.
what's documented. You got to work with what is documented, and if you need to clarify it, you clarify it. That's it.
Mm, interesting. Okay, so let's see. This talks about some of the questions. Will professionals need new training and updated skills to work in an AI environment, and will jobs be replaced by AI? So there was a panel um, that is on this video. There's a free video that AHIMA has, Upskilling the Health Information Workforce in the Age of AI, that gives more detail. And the panelists, I think we talked about that NORC and AHIMA survey that came out before, where they talked about how their organizations plan to use the machine learning and AI in the next 12 months or so. It said 3 of the 4 survey respondents recommended upskilling of the current workforce for HI professionals to succeed amid increased adoption of AI and machine learning tools. I just saw on LinkedIn that some folks that you may know, Mr. Jesse, just received a patent on some kind of AI tool to assist in revenue cycle. But we can talk about that at the meeting after the meeting.
Okay.
So AI tools have the key takeaways that they got from the panel that you may see at the on the video, and the link to the article, which has the links to the videos, are in the description if you are interested in getting more information about this. All the AI tools have the potential to transform job functions and reduce burdens placed on the HI workforce. Panelists noticed that many organizations are increasingly turning to assistive, augmentative, and autonomous tools powered by AI to address workforce shortages, staff turnover, and burnout within the HI profession. I think, well, we ain't gonna have time to do that today, but I think those 3 things right there, we need to have a conversation about. Because really, anyway, technology advancements could alleviate some repetitive and manual tasks in traditional HI job functions, leading to new opportunities that may require upskilling of the workforce. HI professionals should understand how their healthcare organization is using AI and how they may need to get additional training to update existing skills. At the same time, employers should be clear about the role of AI at their organization and make sure employees understand how they fit in and may need retraining. And then last point or takeaway, HI professionals need to be willing to adapt their roles and be open to upskilling as more workplaces embrace AI. HI professionals and students should embrace the idea of continuous learning and keep up with resources and tools that will help them update their skills in this evolving landscape. And why I can appreciate, and I have not watched the video, but I can appreciate like the information in this article. It's not enough. Like, be specific. What is it exactly that they need to do? If you are in this role and you have AI or machine learning possibly looming, I know we talked about kind of transitioning or pivoting over into auditing. Well, there are specific skills that you need to be an auditor. So, making sure that they understand, okay, well, to pivot, these are the things that you need to now, or you now need to be focusing on to market yourself as an auditor. These are the skills, like we talked about, even with data analytics. These are the skills and these are the things that you need to know in order to position yourself in those things. Be specific. It could all be so simple if you just tell us what it is.
Well, I really think that it's like that because they don't know. And 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 for AHIMA specifically, they have attempted to help people. It's called a micro credential, but I think a micro credential is a waste of time. That's what is that?
I do too. I'm not a believer in the micro credential. I don't know, what is that supposed to tell me?
Exactly.
What is that supposed to tell anybody? That I know about it? Hell, I know about it by reading about it. I mean, but what is that confuses me a lot.
Right.
And it's a way for me to pay you more money to say that I know about XYZ, but what does that mean in the world for real? I'm confused about that.
And I told like this is a couple months ago. I had a conversation with the new uh, data analytics
Mm-hmm.
head at AHIMA. She's
Mm-hmm.
she's an RN, when has her master's in health informatics, which that phrase just slays me. But um, Well, nursing informatics, not health, nursing informatics, because that's even worse. But anyway, the whole thing is when it comes to going, getting what you need to know and learning how to separate. Because with the micro credential, like she tried to, because I talked to her because I'm like, I just don't think it's fair that for the healthcare data analytics credential from AHIMA, you have to have a bachelor's degree. And I told us because in this day and age of coding boot camps and people learning all kinds of ways, like the knowledge that you need to know does not. And I told us I understand why, because you need to know statistics in order to pass the CHDA, because basically you honestly need to know statistics and coding and how it would apply. Like you need to know what your what your error rate is. You need to know
Mm-hmm.
how to look at something and tell what your p value is. I
Mm-hmm.
understand that. But once you
Mm-hmm.
learn, but once you can learn that from anywhere,
Mm-hmm.
especially nowadays.
Mm-hmm.
So, and that's what she proposed. She was like, "Well, how about a micro credential?" I said, "No." I said that because that implies that it's not as good as just by nature.
Mm.
So no.
Interesting. Interesting. We about to for those of us in the meeting after a meeting, we about to do some things with this whole data analytics. We about to pull this together. Y'all gonna walk away with a whole skill. Keep playing. Because we got some things that we need to conquer in this world to make these data analytic skills pop. So there's some
because
opportunities out here in these streets. There's a
because
lot of opportunities out here.
because what I really want to do, and I really need to be acting sooner rather than later. All these people that got laid off in tech, I want to do I want to do a a boot camp for them, a medical coding boot camp.
You better say that.
Learn
Let's
these
teach,
skills
learn this skill
and go
and
ahead
pull
over
this together
there. There you
and
go.
welcome to the world of healthcare.
Hmm.
Because it's some things for you. It's some things for you. Interesting. Interesting. What did Carmen say? Oh, yes, Carmen. We or AW727 said, yes, Carmen. We have had to do that too at my job. I love it when my lead says, I know I have to block out time when you ask questions because they're difficult. Wow. Uh-oh, Jesse, I want to attend your boot camp. All right, all right. We all gonna be there. And he gonna give us the information and the keys in the meeting after the meeting. So stay tuned. Stay tuned. So
Thank you.
um, speaking of which, did you know by becoming a patron of the Professional Reimbursement Network, LLC, you're joining a community of individuals who share a deep appreciation for the intricacies of healthcare revenue cycle and health information at large. Here's what you can expect as a value Patreon and member of the Tea Sippers. Yes, we are calling ourselves the Tea Sippers. Exclusive healthcare insights. You gain access to in-depth articles, webinars, and resources covering the latest healthcare trends, compliance updates, and revenue cycle best practices. I need to add ways in which to upskill your skills. Early access. So be the first to receive expert insights and guides, ensuring you stay ahead in the ever evolving healthcare industry. You'll also receive personalized support. Enjoy direct access to our team of experts for guidance on medical coding, compliance issues, and revenue cycle management. We're here to answer your questions and support your professional growth, as well as our favorite community connection. Join a private community of healthcare professionals where you can network, share experiences, and collaborate. And we make sure we keep you accountable as well on finding solutions to common challenges. So, by supporting us on Patreon, you're not only advancing your healthcare knowledge and career. Oh, I forgot to put the whole thing up. See, you didn't even stop me. I forgot to add the whole slide up there. Here we go. So, by advancing your healthcare knowledge and career, but also contributing to the success of the Professional Reimbursement Network, where we can, again, provide the information that we need to pivot and move these informations and resources along. We provide a resource that empowers healthcare professionals like you to thrive in their roles. So thank you for considering becoming a member of the Tea Sippers in Patreon. Check out the link in the description of the video, or you can see the link here, patreon.com/Clarice Warner, the girl with the pearls. Your support means the world to us, and we look forward to helping you excel in the world of health information in the meeting after the meeting. All right, all right. I still need to make that a whole commercial. But we heard it here. We heard it here first.
People don't realize it goes down in the meeting after the meeting. It's a lot of fun. We cover some stuff. And because it's all about, because when I teach coding, I just did a training last week and I have another one to do this week. I tell everybody, like, your role with coding is to create order out of chaos.
Mm-hmm.
That's it. Because when you read these charts, there's all kinds of stuff, but you have to use coding guidelines to put it in some kind of order.
That's right.
It makes sense.
That's right.
Because when you put those codes, the reason why you sequence it is because the coding tells a story.
That's right.
Somebody should be able to look at those codes on the other side and say, "Oh, well, this person had this. Well, this is why they're there, because that's okay."
And that's all what it does. That's all what it does. It's providing information. It's providing that patient's story to anyone who needs to know, based on the information. Like, we weren't there. We didn't see this happen. We didn't see this happen. We don't know what this, but we can pick up that chart. We can pick up the information that was coded to say, oh, well, this is why. Again, your coding supports any medical necessity. Your coding supports why they are in there and why the provider did what they needed to do. It supports how the patient presented and how they went from presentation to out the door. It provides all of the information, all of it. Now, in an inpatient world as well as an outpatient world, it provides it all. And so it's our jobs as steward of the data, because we are data stewards, to make sure that it's accurate and complete.
Period. Because the only people, and I know I clown doctors for their compassionate sacrifice. But to be honest, they are the only people in this continuum that I actually have a little sympathy for, because they are pulled in so many different directions, and they have to document this way for Medicare and Medicaid. They got to document another way for Aetna. They might have to change it around or include something else for Cigna. That's a lot.
But I feel like, do they really though? Do they really? I think if you tell your story, if you document, because they're taught to well, they should be taught on how to document. There's a way to document that meets everybody's needs.
Right.
And getting to the basics, going back to the basics and making sure that they document that way is a lot of the challenges. I know I follow a lot of doctors who are also out here passionately trying to educate these providers and doctors on appropriate documentation that does meet that need. And back in the day, your doctor wasn't even aware of what insurance somebody had, because that's none of their business. Their business is to care for this patient and to document appropriately how that patient is presenting and the care that you're providing, without regard of any payer, That was something that happened somewhere else. And again, so to me, that's going back to the basics for these providers. If they're told, oh, you need to have this for this person, and that's, of course, they're going out of their mind and they're going crazy. And it shouldn't be that way. They should really just fine tune their documentation to do the job, to support the job and the services that they're doing with those patients.
But when you factor in, they have productivity standards too.
They do.
And I think that's the downfall, because you can't you
That's
cannot
right.
you cannot have production and accuracy at the same time. And that in a perfect world that's true, but there are also exceptions.
Yep, all falls back to numbers. Yep, I agree. Oh, I didn't even read it. If they just document all of what happened, it won't matter the pair. I agree with that. And so again, I think everybody walking away with some food for thought, because providers, there are key ways to document, to make sure that you hit all of those buttons that you need to do. Now that whole productivity thing, because it's become production for them as well, unfortunately. And welcome to employment. Welcome to becoming employed providers in this system. That's what you signed up for. So maybe that's a whole other conversation as well, with them,
Mm,
not with us.
right.
Yeah. All right, y'all. All right, y'all. Oh, girl, that's a whole other thing. Yes, it's because of private equity. And yes, there was a recent something I saw recently. I don't know, it was the DOG, the OIG. Somebody has targeted some private equity firm about something. I can't remember what it is off the top of my head, but you saying that, I just remember that. Great conversation. Thank you. Thank you. It's all about the money. Where the money reside, where the money reside. We always say follow the dollar bill, y'all. All right, all right. Well, we are at the top of the hour. Thank you again for joining the Saturday morning tea or checking out the replay. Mr. Jesse, do you have any final words for the
No,
people today?
it's just
No.
only look, learn your craft.
We
That's all I got.
need a t-shirt. Learn your craft. Learn your craft. All right, all right. Oh, she said yes. Thank you guys. Love your perspectives. You're welcome. You're welcome.
Thank you for
So
coming.
was the tea spilled today? Absolutely. Tea was spilled. And if this information was valuable for you, help us share this message with others by sharing the video and subscribing to the channel. Be sure to follow us for more information on all things health information, compliance, revenue cycle, and of course, medical coding. And as you leave, don't forget to hit the thumbs up or the like button. And also, check out the Coding Nurse channel on YouTube. You think he dropped gems over here? Mm-mm-mm. You have no idea. She's so silly. T all through Aquatica. Like, thank you, thank you. Wonderful, wonderful. Yes, yes, yes. She's so silly. Okay. Um, so again, make sure you check out the Coding Nurse channel on YouTube. And as we've all expressed, this has been a great session today. Thank you all for joining. And remember, be safe, be kind, and don't wish for it, work for it. Until next time, take care, and we will chat in the meeting after the meeting.